Good afternoon, everybody. Oh, it's still forenoon. Thank you very much, Dr. Rao and Dr. Mohanty and Dr. Bipin, to give me this opportunity to be here. And actually, I'm changing the entire menu now. It's a totally different ball game, aortic arch surgery. So, as we know, it's one of the formidable jobs when we are talking about the aortic arch, one of the most difficult segments of the aorta to be approached surgically. And there are a lot of issues involved, which I'm going to discuss in some detail, and also achieving the desired outcomes and how do we do that. That's what my focus of this talk is going to be. This is the hospital where I work, Medanta, and greetings to all of you from there. And let's see what by definition is an aortic arch aneurysm. Any aneurysm which is measuring more than 5.5 to 6 is something which needs attention because there's a chance of rupture or remotely a dissection. And generally we do not address these arch aneurysm unless they are symptomatic, number one, or otherwise there's a definite growth in the size of the aneurysm. Because as you know, unless you have a great experience in handling these aneurysms, you have to be very careful in choosing the patients. You can't be applying these to borderline cases and going ahead with the arch replacement because it has its own morbidity and mortality. When we talk about the arch replacement acute dissections, once again, it's a very tough job to handle, but any arch which is having an intimal tear, in addition to intimal tear in ascending aorta or just an isolated tear, needs to be taken care of at the same time. Or if there's a burst arch, and in my entire experience, there's only one case where I had to do because there was a ruptured aortic arch dissection. And one of the rare indications for replacing an arch in a patient with extensive atherosclerotic disease of the arch and having recurrent transient ischemic attacks or strokes, in this particular elderly gentleman who came with multiple strokes to the hospital and detected to have this kind of an aorta, and we had to change the aortic arch. Well, the three issues which are of primary importance in aortic arch surgery are the organ protection, essentially the brain, but of course the other organs cannot be ignored. But brain is of prime importance because, as we will see, the outcomes of aortic arch surgery are synonymous with the outcomes of the brain. Any neurological injury would mean a high mortality and morbidity. At the same time, customizing the aortic arch surgery as per the needs of the patient, how much of the aorta has to be replaced, which is absolutely essential. And hemostasis is of utmost importance because bleeding is something which could destroy the results of these surgeries. Preoperative workup is fairly standard as we do for any other open heart surgery. The basic focus being that we have to look at various organ subsystems as to how they would sustain this kind of a major surgical procedure. The basic premise, the brain requirement of blood supply is very high, and therefore we have to ensure that we do not compromise the brain viability because we compromise the blood flow. And another important issue which is very relevant to the brain is the autoregulatory mechanisms. And we have to maintain these autoregulatory mechanisms and choose the modality of brain protection which gives utmost importance to the autoregulation of the brain, because the outcome of brain surgery, outcome of heart surgery depends on the preservation of the brain. The neuroprotective methods which have evolved over a period of time, as we know, the gold standard had been the total deep hypothalamic circulatory arrest till that was a modality which started in 1975 by Randy Greep and his team from Stanford. And later on, as time went by, then retrograde cerebral perfusion was added as an adjunct to this modality of brain protection, and of late now, selective antegrade cerebral perfusion, which could be unilateral or bilateral. We shall address to these topics in small details for the interest of the postgraduates. We know that any kind of hypothermia does not reduce the brain metabolism to zero. If you look at the CMR-OT values, even at 18 degrees temperature, you cannot achieve a zero CMR-OT, which is basically the metabolic requirement of oxygen by the brain is still there, and metabolic activity is still going on even at 18 degrees temperature. So therefore, what we are trying to do is trying to achieve a kind of a perfusion whereby we maintain the circulation of the brain, maintain the milieu of the brain, and also maintain the pH of the brain, which ensures a much better outcome in terms of the brain preservation. Well, when we talk about the perfusion, the most important thing is how to get an arterial access. There are multiple arterial accesses, as we all know, and most of us have had experience in dealing with these various arteries for cannulation. But as of today, the axillary artery is by and large the most commonly utilized access for perfusion of the body for a variety of aortic surgeries for a variety of reasons. Namely, the X-ray artery is one artery which is probably immune to atherosclerosis, doesn't get involved very often in dissections. Of course, we have seen X-ray artery also having dissection flaps, but with carefully manipulating, we have been able to cannulate the true lumen in these patients as well. Exposure doesn't take more than 5 to 7 minutes. Usually in the initial part, yes, it does take a little time, but subsequently as you gain experience, you don't take more than 5 to 7 minutes to expose the X-ray artery. And we use this X-ray artery for a variety of cannulation indications, not just for aortic aneurysms or dissections, for many other reasons like porcelain aorta and all that stuff, which probably I'll talk about in this presentation. And these are the pictures showing the X-ray exposure and the prefabricated X-ray cannulas that we use routinely. Of course, there's a problem that Edward has stopped importing this cannula anymore, so we have to still use the cannulas which we have been using earlier. And at times, if you don't have the cannula available, you could just put in a graft on the X-ray artery and use that as an access. But at the time of cannulation, it's very important for my postgraduate students to understand that one has to be very careful. As I said, the friability of this artery is very important. It's a very, very fragile artery, and therefore you have to be very meticulous and carefully cannulate this artery, otherwise you could produce an iatrogenic injury to this artery. Well, when we talk about the profound hypothalamic circulatory arrest, it is the simplest technique which we utilized for many, many years. Until 2012, I was one of the main proponents of this modality of brain preservation. It had no add-on requirements, simple cannulation, just cool down the body to 18 degrees, no special instrumentation needed. You just stop the circulation, you get a dry field. But the basic disadvantage is being a long bypass time. You have a long cooling, long rewarming, multiple coagulopathy issues, which were a major issue in getting the desired outcomes of the surgeries. Well, as we know that, whereas when we talk about the antegrade cerebral perfusion, it has definite advantages. It has an even distribution of the perfusate. It does not have, there's no need to cool down to 18 degrees. We just generally cool down to 27 degrees. But if I'm doing a total arch, I usually cool down to 25 to give me some little extra time, maybe just for my own mental comfort. And preservation of the cerebral blood flow autoregulation, because at this temperature, usually the autoregulation mechanisms do work. And the buffering power of the hemoglobin, which maintains a good milieu of the brain environment. Well, if you look at the neuronal injuries, you find that the maximum neuronal injury is seen in patients who have gone through deep hypothalamic circulatory arrest. The incidence did come down in patients who had retrograde cerebral perfusion used as an adjunct, but of course there are time limits. Usually, if you are using a RCP in addition to a deep hypothalamic circulatory arrest, maybe about 60 minutes of time. But in one patient I still remember who had large eroding aneurysm through the sternum, I utilized this modality for 83 minutes with a good neurological outcome. But that's an exceptional case. But in selective cerebral perfusion, your results are just little inferior to just giving a regular anesthesia. So therefore, the neurological outcomes are certainly better in patients where you use unilateral or bilateral antegrade cerebral perfusion. Well, in a review article published from Austria, at present time it can be said that no one technique of cerebral perfusion has been shown to prevail unequivocally. Aortic arch surgery remains by and large surgical art. Now what's important is also how do we monitor the brain. The brain has to be monitored all through these procedures, and it gives you a lot of mental comfort. We use NIRS on all the patients who have to undergo any kind of cessation or cutting down on the cerebral perfusion. And we find it extremely useful modality. In going by the numbers, it gives you so much comfort that you are in a position to change your flows, change your duration for which you can run low flows and all that. It gives you a comfort that probably the brain outcomes are going to be okay. Some people still use EEG and the evoked potentials. Most of the people who are using deep hypothalamic circulatory arrest as a modality of brain protection. Well, these are some of the intra-op pictures of the NIRS. As you see here, the values of 55, 60, which is quite okay, and you see the matching results on the left and the right side. And these are the electrodes used for NIRS, which we put on the forehead. Basically, gives you the oximetry of the frontal lobes of both the sides. And as you can see here in this patient, where there's a complete stoppage of the blood circulation to the distal part of the body, there's a cerebral perfusion happening, and you have 47 and 41 as the NIRS values, which give you a comfort that brain is getting adequately perfused and on both the sides. In our own experience, Generally, in addition to, of course, using NRS, we also use topical cooling for brain protection with mental comfort that probably uniformly cools down the brain. Well, in our own experience, the current modality that we follow is right axillary cannulation in all the patients, sternotomy, cardiopulmonary bypass, core temperature down to 25 to 27 degrees. As I said, 25, it gives us a little more comfort to do patients who have extensive arch aneurysms, where you have to do a partial arch or a hemi-arch. Probably 27 is good enough. More so in patients with dissections, where you end up just doing a hemi-arch procedure. Right-sided perfusion and arch is open, and once the arch is open, you flow down to 5 to 7 ml per kilo. Word of caution here, the recommendation is 7 to 10 ml, but we found, because we do a CT scan on the first post-op day on all these patients, when we were flowing at 7 to 10 ml, we found there was some incidence of subdural hemorrhages and also subarachnoid hemorrhages on the first post-op day CT, which was worrisome. So we cut down to 5 to 7 ml. And with that, the results have been predicted, very predictable and good. And we still find sometimes in patients, even at this flow rate, very small SDH. And I think sometimes we might be over-ambitious about the modified ultrafiltration. We might be taking out too much of water and the brain shrinks, and there's possibility of SDH coming up because of that reason as well. And resume the flow once the arch part is done, and then proximal repair while you're flowing fully. In our own experience at Medanta from 2009 to 2016, the total aortic surgeries that we have done is 710, out of which 336 patients required some kind of cerebral protection. Deep hypothermic circulatory arrest till 2012-2013, 96 patients, and moderate hypothermia with cerebral perfusion, antegrade cerebral perfusion, 240 patients. 2 mortalities and 4 patients who had transient neurological deficits. We did not find any major neurological events. Whereas with the deep hypothermic circulatory arrest, we used to find on the first post-op day, patients are very irritable, very restless. They may not have definitive neurological dysfunction. They might not have any focal signs, but they used to be very irritable. I think probably the deep hypothermia could contribute to this kind of a transient misbehavior of the brain. Well, this is a patient's picture who underwent complete aortic replacement from the root to the hiatus in 2 stages. This is after the first stage on the first post-op day, and this is antegrade cerebral perfusion through the axillary artery, as you can see, cut in the infraclavicular region. And most of these patients, we are rest assured, they'll be fully neurologically intact when we come back and see them in the morning. We have a protocol where we do their CT scans every morning on the first post-op day, and ensure that we have not produced any neurological deficit. If at all you have even a small subdural hemorrhage, and if you give them anticoagulation, which is part of their valve replacement which has been done on them, you could worsen them. So generally we do a CT scan before we start anticoagulation on any of these patients. Well, the issues regarding the surgical part are how much of the aorta to be replaced, the conventional repair or the distal, how we do the distal anastomosis, supraortic vessel reimplantation, the different methodologies, the frozen elephant trunk, the arch first technique, the double graft technique, and the hybrid debranching. I'm going to briefly talk about it. Well, this is the conventional arch replacement that we do. We do the distal anastomosis first at the level of the distal arch or the proximal descending thoracic aorta, and then reimplant the arch vessels, and then come back and do the proximal anastomosis. Well, this is an intra-op picture of a patient who had a total arch with a Bentall procedure, a perfect outcome, no bleeding, and a perfect lie of the graft. And I have been using these branch grafts for almost 7 to 8 years now, and I feel very comfortable using, because my total time I spend doing a hypothermic perfusion or a total circulatory arrest to the distal part of the body is around 40 to 45 minutes. And of course, this is one of the difficult areas where you have to replace the arch in an acute dissection situation. This patient came with a type A dissection with a large intimal tear in the arch. You can't leave it behind. You need to replace the arch. And one has to be very meticulous in changing them, because these aortas, as we all know, are very, very fragile. And another difficult situation where you have infected aneurysms like this, a patient who was a drug addict and he had developed a massive arch aneurysm, who came to us with imminent rupture, and he had recurrent hemoptysis, and we had to change his arch in a emergency situation. Well, briefly talk about these things which might be of some interest to my colleagues here and also to the postgraduates. Sometimes very difficult to make a judgment whether to go from the midline or to go from the side. In a situation like this patient came to us from Uzbekistan with a large aneurysm just in the distal arch, just beyond the left subclavian artery. I was debating to myself whether I should go from midline or go from the side, whether it will be accessible from the midline, but I decided to go from midline, and ultimately we found that it was not difficult to do it, and we could get this result after this is a post-operative CT scan. And similarly, in this patient who came to us from Indore with a ruptured distal arch, with a ruptured arch aneurysm, and we had a massive hemothorax, so going from the side was like committing a suicide. So I decided to go from the front and replace the arch and the desired outcome. The message thereby is that it is possible to go even up to the proximal descending thoracic aorta from midline with fairly easy technical access to the distal aorta. It's not at all very difficult. Worst scenario, you might have to extend the incision of the sternotomy by making a T-cut in the thoracic cavity. Well, as we know, Hans Bo's contribution to replacement of extensive aneurysms of the aorta like this, where you need to do staged procedures, an elephant trunk procedure first, putting a graft in the distal aorta. We have modified this technique a little bit. Of course, this is not the forum to discuss that, and pull back the graft and reimplant the arch and complete the procedure. Well, this is a patient I always show in my presentation, done at All India Institute when I was a faculty at All India Institute, who had an extensive aortic aneurysm starting from the aortic root, aortic bifurcation. In addition, there was a large iliac artery aneurysm, and we did him in 2 stages. Young boy, he was just 25 years of age, and this was the result after the first surgery. 5 years later, he came back with a small aneurysm at the implantation site of the renals, probably because the underlying, there's a aortitis, a disease of the aorta. So whatever island of tissue we left behind for reimplantation of the renal artery also became aneurysmal. This is the graft that we routinely use, prefabricated arch graft, very easy to use. And these are the steps of the operation. You do an elephant trunk, you put the graft inside the distal aorta at the level of the isthmus, pull back the graft, reimplant the arch vessels, and 2 weeks later go back and do the distal part of the anastomosis and complete the aortic replacement. Using a frozen elephant trunk is an option. I have no personal experience for a variety of reasons. Number one, cost is the most prohibitive issue in this, and I don't think as of today our patients are prepared to pay that kind of money. Of course, some people have indigenously in Chennai designed their own something like a frozen elephant trunk, and they've been doing it with good outcomes. Well, regarding what technique to be followed, whether to do a single patch, the Carroll patch technique, or to do a multiple implantation on the arch vessels, well, that's depending on your own comfort. Most of the centers in America are still doing the Carroll patch technique, but this could be a problem in patients who have extensive atherosclerosis of the aorta. Most of the arch vessels are usually free of atherosclerosis, so we prefer doing direct implantation of the arch vessels onto these prefabricated grafts. And these are as we said, a very good technique to use. They are a little costly, definitely, there's no doubt about that, but they can be utilized safely in patients who have atherosclerosis in the aorta or also have dissections in the aorta. Most of the Japanese centers, they're using these prefabricated grafts. Well, there are other unusual methods which I have no personal experience in, but could be utilized. They have their own pros and cons, some advantages, some disadvantages, which I am not going to discuss. Another subset of patients who have got distal arch aneurysms, where the aneurysm is actually occupying the distal arch and the proximal descending thoracic aorta, well, these aneurysms have to be accessed from the side unless some kind of a hybrid procedure is applicable to them. We still do them through the femoral cannulation, thoracotomy, open them up and interpose a graft. Similarly, you have this entity, these large sacral aneurysms in the distal arch, who sometimes have recurrent TIAs and strokes because of embolism from these and thrombi which are within these aneurysms and require a surgical resection. Well, a lot of work being talked about in the hybrid procedures and debranching and all that. As I said, we tried doing it, and we had 2 patients where we did this, as you can see in this particular panel of pictures, and both these patients ended up with a retrograde dissection descending aorta, and unfortunately we had to take both of them up for surgical intervention at a very quick gap, and therefore somehow I lost my faith in these techniques because of these two initial failures. And I'm not saying, I'm not denouncing the procedure, I'm only trying to say that one has to be very judicious in applying this kind of a modality to our own patients. Well, the other issues, the hemostasis, as I said, the most important issue, because as we know, these are operations which require a long cardiopulmonary bypass, hypothermia, they have pre-existing coagulopathies sometimes, long suture lines and multiple suture lines, the porosity of the vascular grafts. One has to be very meticulous in suturing them. A perfect surgical suture line is the best that can prevent the bleeding, and time spent to do them properly, like when you're doing an arch aneurysm, the distal anastomosis has to be done with the utmost meticulousness, because there's a commonest site of bleeding and one tries to rush through it because you have some time limitations. One should pay attention, even if you have to spend 5 to 10 minutes extra, it doesn't matter, because if you have bleeding from the distal suture line, it becomes very difficult sometimes to manage. And you have other products available, the various glues. We ensure we have platelets, the single donor platelets available for all these patients when we operate. We use cell saver for all of them, and we routinely do conventional and modified filtration to achieve the desired hematocrit so that the bleeding can be minimized as much as possible. Well, total of 336 arches that I have done at Medanta. I am not including the earlier experience at All India Institute and at Max Hospital, out of which 165 were hemi-arch procedures, 4 partial arches, 60 total arches, distal arch 72, elephant trunk procedures in 10 patients, and 1 had a penetrating ulcer of the aorta. And perfusion technique, which I have already discussed in detail, I don't want to discuss any further about this. And the outcomes have been fairly good, 30-day mortality of 2.56%, and with fairly acceptable end organ damage. Survival at 1 year 93% and 5 years 81%. To conclude, the aortic arch replacement must be kept simple, and so far the conventional methods of distal anastomosis first remains the gold standard of treatment. The use of femoral artery cannulation must be avoided in favor of the right axillary cannulation. We have totally switched over from the femoral to axillary cannulation, and brain protection during aortic arch exclusion is best achieved through selective antegrade cerebral perfusion, which could be unilateral or bilateral. We have been using mostly unilateral. We have never used bilateral because I don't think I have cannulas which are selective cannulas for the carotid available with me, and we have had no regrets about the outcomes of using a unilateral cerebral perfusion. And during the distal arch repair, the moderate hypothermia of 25 to 27 degrees circulatory arrest may be carried out safely. So if you are utilizing around 40 to 45 minutes to do a total arch, I think you are in a safe zone to get the desired outcomes. Thank you very much. Can I go to the second one? This is mainly meant for the postgraduates as to how to ensure that your Bentall procedure is bleeding less. Boss, can you help me out in switching over?
One question I had, you give antegrade cerebral perfusion to one carotid.
Yeah.
Because of single, do you, that means you are working under the assumption that the circle of visits is intact in everybody?
I read something about it, in about 25% of the patient there is an inhabitation of the circle of Willis. But as I said, clinically we didn't regret it. There another subset where you have bovine arches, where you have the common trunk which is dividing into left common carotid and denominator, where we plan for both things. So you have perfusion both the things, because as you must have read the literature, the incidence of aortic aneurysms and is much higher in patients with bovine arch. So quite a 5% have a bovine arch where we climb both. But honestly, we have had no regrets with unilateral cerebral perfusion. But with the analysis, with the values sometimes drop on the left side, then we increase the perfusion and then we switch over to PH strategy, which I'm sure you don't agree with me that PH strategy is a superior brain protection mechanism. But we use carbon dioxide in those patients to ensure a good cerebral perfusion on the contralateral side. And the moment we start carbon dioxide, you'll find the numbers on the left side also coming up, and we increase the flow slightly. Generally, I'm sticking now to 5 to 7 ml because of this apprehension of intracranial hemorrhages. But in those cases when we have slightly increased the flows to about 10 ml, we have been able to achieve same numbers on both the sides.
And what about the left-sided vertebral artery?
Well,
some people cannulate all three, subclavian and both carotids.
Subclavian, that's right, but we have never done that. No, the contralateral is talking about. And some patients, unfortunately,
the picture we have shown two
that was a sketch diagram, but our own experience, we just use right axillary.
This question is a bit off the track, like especially in the pediatric age group when you do the anterior brain perfusion. Do you monitor your right radial artery pressure and use it as a guide?
You monitor the right radial, but the problem is when you have a cannula inside the X-ray artery,
That's true.
that pressure goes off.
But if you have a graft,
we
then
are
you can.
analyzing it more from point of view once you decannulate to be sure the right radial trace is there, that you have not hurt the right X-ray artery. Well,
But
that's
if you have
very
a graft-
important. That's part
if
of
you
the.
have a graft, then you can monitor the pressure.
Pardon?
If you have a graft.
Yeah, if you have a graft, but since we have this cannula available to us right now, and technically much easier to cannulate with this cannula than to put in a graft, then you've seen once you put in a graft, because way back, I think, 97, 98, when I was at All India Institute, we didn't have these X-ray cannulas, and we used to put a graft, and there used to be so much of bleeding from the needle holes of these grafts, and you would have to keep on some sucker there to ensure all the blood doesn't get lost. And so therefore, this is a much simpler thing. You put in a cannula, and actually since the cannula has been withdrawn from the market by the Edward, I'm looking for an alternative from Medtronic, which is not labeled as an X-ray cannula, but looks like an X-ray cannula, so I might start using it. I've asked them for a sample of that cannula.
What about the pediatric age group? You're still doing anterior perfusion for the arches in children?
Circulatory arrest.
Sir, coming back to what Dr. Sharma had commented, in 2005 I was working with Dr. Cherian as a fellow, and that time we had an anesthetist because we didn't have needs at that time. So again, the issue of what is the surety, or what is do we have any control over ensuring that the opposite side of the brain, that the left side of the brain is perfusing well or not. So in that scenario, we had an anesthetist who used to pass a IJ cannula reverse, not in the conventional fashion, but and he used to tend to measure the venous
Oximetry.
saturation of the bulb.
That's the same as
So
jugular,
yeah, exactly. So, but
jugulovenous.
in absence of needs, if that access is there on the opposite side, not on the right
Correct.
side, so on
Correct.
this side, so the saturation there will be a rough, at least a crude predictor of that thing is working.
The other crude way of looking at it is when you're doing a unilateral cerebral perfusion, when you're opening up the arch, you find quite a bit of flow coming
Yeah.
from the left carotid. So that gives you some comfort. Of course, NIRS is the ultimate. I think that gives you tremendous comfort to be sure that you're perfusing the other side of the brain.
Yeah, I must make a brief observation here. You have, of course, a brilliant series. Everybody knows that. I have got a fairly large experience on this area here, and may not have done as many as you have done, but close to that. I would like to say that there's one thing that I learned over the years is that, okay, cerebral protection is important, and that we do, and I follow exactly the same what you have been doing, and it's been hugely popularized by the Japanese people. But what is more important after having done so many cases, that I realized that the lower body circulatory arrest also a certain % of patients can cause problem. So last 3 years I have been cannulating the femoral artery as well as the axillary artery, and only the period of distal anastomosis is a total circulatory arrest. As soon as I finish the distal anastomosis, which is usually a 15 to 20 minute job, I start the femoral circulation simultaneously with the antegrade cerebral circulation.
So actually,
So
you
that
don't.
is sort of protects the lower body, and I have seen a certain number of patients who, after a second or third, they suddenly find their liver enzymes going up in thousands and 2000s, and 1 or 2 patients had a lot of problem, and they develop in fact renal failure as well. So I thought that this double perfusion, lower body perfusion, also helps tremendously in the post-operative morbidity, and you are able to extubate them as quickly as 1 or 2 days. Even in fact, most of them are extubated the next day within 18 hours.
So the prefabricated arch grafts that we use, it has an arm for the perfusion also. So if you are very particular about it that you want to perfuse the lower part of the body, you do the distal anastomosis, put a clamp on the graft, and switch over from the X-ray perfusion side to the side branch, graft, and start perfusing the lower part of the body.
Yes,
You don't
that's
have
right,
to.
but these prefabricated grafts are only available last 6 months.
No.
To us at least. I
Okay.
don't know. In Mumbai, it
Okay,
was not available.
I have been using these grafts, I think since 2006,
Yes, but they-
2007.
for some reason they are still not available. In fact, every week I'm doing at least 1 or 2 cases like this, and now only in last 6 months or 8 months that I'm getting this.
Datascope is the one which is making. I think you should get in touch with.
Vascutech.
You should get in touch. No, Datascope. The Mackay and that combination. I think you should get in touch with Mr. Rajiv
Now
Mahajan. He
we've
is
got it. Now
supplying
we
to
got
us.
it from Vascutech. We are getting that. The other thing that I wanted to ask you, that in most cases I'm a little more aggressive on replacing the whole arch, especially if they are Marfan, even if they have only ascending aortic or a to innominate disease, and I would rather go and do an elephant trunk. The only issue that I have faced that we don't have a frozen elephant trunk graft. So the putting in the graft in a distal aorta, which about 10 centimeters or so, when I push it down into the normal aorta, That's where I've been finding it a little hard to push it down. How do you have
That's
any
precisely
technique
what
for
I
that?
said. We have modified the technique. We had a problem in one of the patients where isthmus was small. So what I do now, I take a separate graft, separate straight graft, sew it up to the annulus. Actually, if you look at the Teramo people, they have come up with a graft, the arch graft, which has a collar at the level of the isthmus. You just put the distal limb inside the distal aorta, sew the collar to the isthmus. You don't have to do all this, invagination of the graft and all this stuff. Secondly, if you are still doing the invagination of a graft and you have these branch vessels, you cut the branch vessels to smaller size, because the amount of Decron that you need to push into this distal thing while you are pushing it in will come down. Otherwise, it's very difficult to do it. So what we have started doing regularly now, take a graft, sew it up to the isthmus, and then take this graft, the arch graft, and sew that to that collar that you have created. You don't have to do this imagination business at all.
The other thing that I've noticed that you have done this distal arch aneurysm through mid-sternotomy. I have done those recently. I've done about 4 of them, and I've done a clamshell incision. It gives a brilliant exposure. I thought it will have a lot of post-operative issue, but it didn't, especially if you take care of both the phrenics.
No, we
on
keep
either side.
we keep our options open, but generally I've got away without having to do that extension. Just do anastomosis.
No, I'm
You
not
can-
talking about extension. You start off with a clamshell, bilateral thoracotomy, and you open up. Initially, I used to think that both thorax open would cause a lot of postoperative pain, morbidity.
Actually, if you look at
but
Lars,
actually not. They really recover brilliantly.
Lars Swenson has described a total aortic replacement in one go, and that's how he has done it. So we'll go to the second presentation, which is essentially meant for the residents. Do we have a the light or something? I don't know if it's going to work or not on this. So मुश्किल है. The intellectuals solve the problem and the geniuses prevent them. This is a slide given to me one of my consultants who works with me, and I thought that was a good beginning. And surgeons anticipate them. And it's very important to anticipate these problems, and if prevention is cure, then anticipation is prevention. It doesn't work. Anyway, no point sweating like this at the end of the procedure. I think one should plan these surgeries properly, and one very important thing which I would like to suggest, might sound to be silly, but while you are doing these operations, you have to be absolutely quiet. Operating room, nobody should be making any noise, because most of the time when you get involved with some conversations, you tend to lose your focus on these operations. These operations are one-time operations, they don't give a second opportunity. So one has to be very meticulous and quiet and focused on these procedures rather than looking right and left. Well, as we know, the main purpose of this presentation is how to achieve a bleedingless Bentall, how to achieve a perfect hemostasis. I think it's very important from the beginning to be very meticulous about hemostasis and open up right from skin instant down. You should be very, very careful that there should not be any unnecessary bleeding, because any bleeding would mean more transfusion, and that would mean more problems. More so in redo aortic surgeries, where you have to be extremely careful about the hemostasis. Well, axial cannulation has solved quite a few of our problems. I have discussed this in some length in the earlier presentation. The operation starts by dissecting between the aorta and the pulmonary artery, because you have to get the aorta completely free, and it's very important that you stick very close to the aorta, because aorta has to be sacrificed. But stay away from the pulmonary artery, because if you injure the pulmonary arteries are very, very thin, and it's sometimes difficult to repair them. So when you're separating the aortopulmonary window tissue, be very careful and bring the cautery down to 10 or 15 coagulation, and stay closer to the aorta so that you don't injure the pulmonary arteries. Sometimes, more so in patients who have some kind of aortitis, it's a little tedious job to separate the aorta from the pulmonary artery. Well, this is the end result of separation of aorta and PA, completely dry. Well, the next step is to, after you clamp and you give the cardioplegia, if you are giving into root or into ostia, depending on the lesion of the aortic valve, you transect the aorta right above the coronaries and leave a safe margin of tissue around the coronary, because you have to ensure that you have a good coronary button size, and it's very important, more so in patients with muffins, where coronaries are quite often displaced. Do not cut the aorta without seeing the coronary ostia. If by inadvertently you think, oh, this is the place where I need to cut it, and when you open, you find yourself very close to the ostium. This happens in muffins because the coronary ostia are quite often displaced. Well, then the next step is harvest the coronary buttons. In a situation like this, I particularly chose these pictures because the aortic valve was heavily calcified. Sometimes calcium might be going right up to the ostium of the coronary artery, and therefore one has to be very meticulous and decalcify close to the coronary ostium, and be sure that you don't injure the coronary ostium or produce a dissection there, which can happen if you do it improperly or not in a proper way. Well, after you harvest the left button, then you have to ensure that you mobilize the left button properly, because for any of these button implantation, there should be no tension whatsoever at the coronary implantation site. And this is the left button being mobilized, and you have to free it off completely from all the sides. It becomes easier to mobilize a button in Marfan's because the tissues are very lax, and secondly, the ostia are quite high placed, and therefore you don't require to mobilize quite a bit, unlike the non-Marfan's. This is now the right button mobilized. A word of caution here, that sometimes when you are mobilizing the right button, you can injure the right ventricular muscle, which you are seeing. You should not bear it at all. There should be some tissue on it. Otherwise, there could be very bad venous bleeding from the site, and it becomes very difficult to handle because this entire tissue goes behind the right coronary implantation site. And this is the completed root excision, the two coronary buttons being excised, the valve has been excised, and we have to decalcify the annulus properly, because otherwise the sutures will not take properly and there could be a potential site of bleeding. And next, to size the annulus, it's very important not to oversize the annulus, because if you oversize the annulus, it can be a problem. The valve ring, the sewing ring of the valve should seat perfectly within the annulus of the native valve, because if there's any part of the annulus of the prosthetic valve lying outside this, that becomes a source of bleeding. So I undersize usually by one size than what I get on the annular measurement. After you have done that, we create usually if it's a bioprosthetic valve conduit, we create the valve conduit ourselves using a thioproline, 2 layers. Be sure it's a perfectly tight suture line so that there is no potential source of bleeding from the suture line. Though it's not of utmost hemostatic importance, but if this starts bleeding, it will be inaccessible, almost inaccessible to fix up this bleeding. And then I use interrupted sutures. I never use the plated sutures for fixing up the valve conduit, and it's very simple and easy. Actually, I learned it on an Afghani patient who came to us who had a heavily calcified annulus, and I was not able to get even a 19 size valve in. So I thought if I put plated sutures, that 19 will also not go in. So I decided to do single arm sutures and use the soft felt as a buttressing material, and there onwards I carried on with that technique, and I find it's quite useful. Because most of the surgeons I have seen using the plated sutures for this, for hemostatic reasons. And after you put in all the sutures should be put full thickness right from outside the aorta, whatever little of the aortic rim you have left there, through the annulus, and then finally into the valve, prosthetic valve annulus. And this is the valve, the prosthetic, the valve conduit being seated. And this is the soft fill that we use between these sutures to tie it down, and these should be all securely tied sutures. And look at the annulus properly and be sure there is no gap anywhere, and if there is any, then we put an extra plated suture, as you can see here, to supplement that suture line. But the next step is to get the buttons on, and it's very important, as I said, buttons should be completely mobilized so that there is no tension on the suture line, because any tension on the suture line with a high pressure within the conduit could end up with bleeding. And therefore mobilizing these buttons is very important. There has not been a problem with malperfusion of the left coronary system ever, in my experience. If at all, it's been the right coronary system, which I'll talk about. So therefore you find the most appropriate site where you want to implant the left coronary button. And a word of caution here, the opening which is made in the conduit should be much smaller than the size of the button, because the edges of the button should overlap the Dacron material. If you have the edges sort of sinking in that, then there's a high possibility of bleeding. So you should have the edges of the button overlapping the cut in the Dacron graft. And this is the electrocautery we use, not in all the patients, sometimes, and make a hole in the conduit and suture it up with fibroproline 16 mm, using again a Teflon felt in as a buttressing material. This is the left coronary button implanted, and then at this point of time, it's very important to check the hemostasis of this left button, which we do by putting in a Foley's catheter and injecting the blood cardioplegia into it, and we can regulate the pressure and flow both, because this is done from the pump head, and we can tell our perfusionists to go up to 200 millimeter mercury pressure and do a litmus test for our suture line whether this is in good shape or not. And if there's any possibility of any bleeding, you should fix it up right there with the interrupted fibrinoprolin suture. Again, the right button, and as I said, the malperfusions happen more often with the right than with the left, because the right coronary artery quite often takes different courses. Sometimes it comes straight down, sometimes it takes a tangential course, so one has to be sure where to implant. Depending on the course the artery takes, one has to implant accordingly. So as Rajesh used to say for switches, when we were at All India Institute, he used to say the button should be implanted in such a way that it should flow down like a fountain or a waterfall, if I'm right. So the same thing applies here. As you can see, we are checking with the coronary probe the direction of the coronary, and based on that we choose the right and the appropriate place for the implantation. And this is hole made in the conduit. And again the same technique, 5/0 16 mm Dacron buttressed suture line. And after finishing the inferior edge, I again check with the coronary probe whether the direction of the artery is okay, and it's a unobstructed probe flow into the coronary, because quite often you see, I'm sure at least in the initial part of your experience, you will find after you try to come off, the right ventricle gets distended, it looks ischemic, and it all happens because of the right coronary malperfusion, and then you end up putting in a graft in the right coronary artery. This can be to a great extent avoided. Again, checking the same litmus test for the right button, injecting around 200 ml of cardioplegia at a high pressure and checking whether there is any bleeding from the coronary button site, and fix up if there is any potential site of bleeding. Well then, at this stage, generally we do put some glue, which is actually not to take care of any surgical inadequacies, but to take care of any needle hole bleedings, which could be potentially troublesome. More so on the inferior aspect of the left button and the right button, where I put some tissue spray so that any needle hole bleeding could be taken care of. Then comes the distal anastomosis, depending on whether we are doing it on a clamp or we are doing it an open end technique, depending on the underlying pathology of the aorta. In this particular patient, we are doing it on a clamp, and I use Preoperative 2 layers for aorta, double layer suture line, and using a Teflon felt as a buttressing material. However, in patients who have a dissection where we need to make a distal cuff to obliterate the false lumen, then of course we have to do it under circulatory arrest with the open end anastomosis, as you can see here. And that's a completed procedure with hardly any bleeding, as you can see. And I think one meticulously sticks on to these principles, and one can achieve a desired outcome in terms of the bleeding. Well, there are difficult situations in patients who have dissections, because the quality of the aortic tissue is very poor. As you can see here, this acute dissection being operated, or a massively dilated aorta, and you'll be shocked to know this gentleman was an IIT graduate from Jodhpur who ignored himself and reached this stage of his aortic presentation. And otherwise, ruptured aortas, where again you are always in a rush, and extensive and bad dissections. A young gentleman was doing weightlifting in a gym, and from gym he straight came to us with the acute dissection of the aorta. Adherent aortas, sometimes you have more so in patients with aortoarteritis of variety of etiologies. Heavily calcified aortas. This gentleman, 80-year-old gentleman with extremely calcified SN aorta with triple vessel disease. So these are difficult situations. Similarly, coronary involvement in dissections. Most of the times we can recreate the buttons, as you can see here. This is another patient who had a dissection in the entry point near the right coronary ostium. The right coronary button was explanted, and we repaired it. We felt we could do it, and you can see in this particular situation, yes, we could salvage the right coronary artery. Again, a right coronary artery dissection. Most often the dissection goes into right coronary than the left. And this is a repaired right coronary button. However, in certain situations, the coronaries are badly damaged, as you can see here. We have no choice but to close that ostium and put a graft on the right coronary artery without wasting too much of time. This is a patient who had a completely avulsed right coronary artery, like a nubin of tissue. And the difficult situation, of course, is patients who have endocarditis, and they have large root abscesses, as you can see here. And another patient with a huge root abscess, and a patient with infective endocarditis of the aortic valve. Totally, completely damaged tissues. We try to clean up the whole root, debride the root as much as possible, and we have found a very good alternative to our homografts. Since homografts are not available to us, we have been using stentless valves. I think since 2005 I did the first one when I was at Max, and coincidentally this patient came for follow-up yesterday after 12 years. I mean, he's been coming regularly, and his stentless valve is still doing well. He had prosthetic valve endocarditis. He had an AVR done somewhere and came with very bad endocarditis. I was planning to do a Ross, but when I went inside, I found the tissues very, very messy. I couldn't think of a Ross procedure, so I gave it up and chose a stentless valve. And of course, the redo is another situation which could be challenging. And here, the main important issue is the retrosternal space, and one has to meticulously work on it, pre-op CT scan to be sure that we have enough retrosternal space. If not, then you have to go on pump from the axillary femoral vein, cool them down, and open the sternum only when you reach a temperature of 18 degrees. Well, surgical strategies are liberal use of Teflon felt, as you have already seen, and clean suture lines and clean techniques of suturing and optimal usage of hemostatic agents. This is a patient who had undergone aortic valve replacement by one of my very respected teachers in 1989 and came back to us, I think 4 or 5 years, 2011, with a post-AVR dissection, and we had to replace. This is another very difficult subset because quite often these aortas are very unhealthy looking aortas, and everything is adherent, as you can see here. And some of these patients, when we feel that we cannot harvest the left coronary button, we use the so-called Swenson's modification, where we put an interposition graft from the left coronary button, as you can see here, do the rest of the procedure as usual, and implant the left coronary interposition graft straight onto the ascending aortic conduit. Quite often these days we have to redo aortas because they had an underlying dilatation of the aorta at the time of surgery, initial surgery, but unfortunately just aortic valve replacement was done, and they come back within 2 to 3 years with a large aneurysm or a dissection, and we need to attend to them. Quite a big chunk of our aortic work is also from this subset. And of course, one of the difficult situations, an extensively calcified aorta, it's not actually a porcelain aorta. One of our radiologists called it a malignancy of the aorta, and the calcification extending right into intraventricular septum and also into the mitral valve. And this is the excised specimen, and we have evolved a very good technique for dealing with these porcelain aortas. In fact, I did one last week also, who had come from Nagpur, sent by one of my students from Nagpur, and this is what you get to see. You cannot at all venture to clamp these aortas. You're going to have a major stroke. A post-Ross dissection, a very rare entity. And Dr. Cherian had done the Ross procedure, so I met him in one of the meetings, and I told him, sir, I have redone a patient who had a post-Ross dissection, and we have done the Ross. Very unusual thing. And of course, this is a child I operated at All India Institute when this child was only 18 months of age, had aortic stenosis, had undergone a balloon dilatation, developed endocarditis, and I did his root replacement using a 17-size St. Jude valve and hand-sewed a graft onto it. And this is CT angio done, I think 1 or 2 years back. They are settled in Saudi Arabia. His father is working in some company in Saudi Arabia, and even today his 17-size valve is doing quite okay. This is probably the youngest Bental that I have ever seen happening. Well, a close follow-up of all these patients is very important. They could end up with problems or complications which could be seen at some stage in the natural history, either the dilatation of the rest of the aorta, dissection of the aorta. So we do a close follow-up on these patients with routine or regular CT scans. And the last patient I'll show you, this patient again I had done at All India Institute. I had done a Bental procedure using the wrap technique, because that time we used to wrap, and she came with this kind of an X-ray. I thought that she developed a pseudoaneurysm. We took her up for surgery, and a very interesting thing that I found, that we used to make a Cabral fistula that time between the perigraft space in the right atrium. There was no bleeding from the conduit, but that fistula had opened up and continuous venous ooze from the right atrium into this huge cavity. So fortunately we didn't have to go on pump. So we had cannulated though, but we didn't have to go on pump. Once we opened up, we found this was the picture. And as we know that with the RAP technique, there was a high incidence of pseudoaneurysms from a variety of suture lines or from the coronary implantation site. Another patient that I had operated myself, he was from Lucknow and he had pseudoaneurysm from the left coronary button implantation, and I had to go back and do him. Biosurgery definitely offers and help by way of simplifying and shortening the surgical procedures. It improves the hemostasis, reduces the blood loss. You can be more aggressive in dealing with your aortas. You can do more extensive aortic surgeries. It expands the spectrum of the lesions that you can operate safely and reduce the surgical risk in case of any coagulation disorders. And variety of hemostatic agents, the platelets, the filtration, and of course, the sometimes a roller gauze, which comes to your saving and difficult situation. We have not hesitated. If there is a slow ooze, we have not hesitated at all to pack the thing and bring out the roller gauze from the suprasternal area, and next day morning go back and pull. You don't have to go to the operating room. You just do it in the ICU. Just pull out the roller gauze and you find they don't bleed. It was just a kind of a ooze which was happening at the time of surgery. But one has to be making a fair judgment. You cannot leave behind a major surgical bleeding and come out. So patient space, and this is an elderly lady at 82, she underwent a Bentall procedure, so age is no more a contraindication. I saw one lady yesterday in my outpatient who was 77 and coming for surgery this week. So tremendous progress has been made in the surgery of the aorta. Technical advances in various operative techniques have yielded better outcomes, and aortic root surgery remains a challenge because of proximity to the coronary arteries, aortic valve, and other vital structures. And I should express my gratitude to my friends, my teachers, and to all India Institute, which provide me this platform to do whatever I've been able to do. Well, it depends on the size of the SDH. If the SDH is small, it does not produce any compression, there is no midline shift, neurologically patient is okay, we go ahead with the extubation, of course involving our neurosurgeons, and in that case we do another CT on the second post-op day morning if we find it's not growing, and at the same time do not give any anticoagulation to them. We do not anticoagulate, we even take out the heparin from the flush lines that we have in, so we routinely monitor them with the neurosurgery people. If they at any point of time or we feel that he is deteriorating neurologically, then definitely we'll push them into exploring. But most of the time, 95% of the time, we don't require to do anything. They're very small SDHs, and I think one thing which I have learned over a period of time is also that we should not be doing too much of ultrafiltration, modified ultrafiltration, because that shrinks the brain and that might actually be a potential cause for a SDH. Just cut it down to 500 ml. I used to do much more than that because I want to get a hemoglobin around 12-13 grams, which would ensure less bleeding chances. And one thing more I'll tell you, which I learned recently, of course, if there's a bleeding from the back wall of the conduit, and you feel it's because of from the annulus or something like that, it's usually not so. Most of the time it's the coronary, which we don't see very often. The only treatment you have for that is you have to clamp the aorta again, cut the conduit at some place, and reinforce your inferior edge of the coronary suture line by a couple of interrupted sutures. No, that of course we take help from our neurosurgeons, and sometimes we have not given anticoagulation even for 7 to 8 days. And we found generally they regress within about 48 to 72 hours. And they are neurologically intact. Mostly we end up extubating them on the first post-op day.
Thank you, Dr. Ban. Thank you very much.